Venkataprabhakar Guduru. Oh, so Dr. Venkataprabhakar his paper is on DMEK for ICE syndrome.
So good morning, everyone. So my talk is on DMEK for Irido Corneal endothelial syndrome. So eye syndrome is basically where endothelium gets characteristics of epithelium, where they pass on to the trabecular meshwork and onto the iris, causing raised diopes and iris defects. So coming to the management options, the main problem is the loss of corneal clarity, where we have to go for a corneal transplantation, where PKP and DSEK were mainstream, where we thought of why not do DMEK, because it has its own advantages, like lower potential for rejection because less tissue is there, and most of these cases have peripheral anterior synechiae, so you don't have much option for going for bigger incisions. So DMEK can be managed with a small 3 mm corneal incision, and as such these eye syndromes have more chances for glaucoma and raised diopes, and with DMEK the need for longer steroids is less, and of course there is no change in the refractive status, where many of these cases happen in the young population. So we included 6 cases, 6 eyes, where we have evaluated intraoperative technique, visual acuity, endothelial cell loss, and IOP fluctuations for 3 years. So these are few interesting cases, where this is a 52-year-old lady who presented with decreased vision, and we can see a pulsatile vessel here, where we can see active blood flow in this, and it's pulsating. And the challenge in this case is, if it bursts during the surgery, it can become a blood bath and it will be very difficult. So in this case we managed with a wet unipolar cautery by cauterizing 2 ends of the vessels, and you have to be careful enough where you have to do enough cautery here. Even if a small track is left behind, it will start bleeding like anything. So once that is done, we have cut the both ends with micro scissors. So basically the challenge in eye syndrome is that we don't have a good iris. So for DMEK you need to have a very good iris so that you can manipulate the tissue and attach it to the cornea. So whenever you are doing an ice, you have to plan the surgery in such a way that your iris is in normal architecture. So phaco has been done, and it's just a regular DMEK where graft is injected, it's manipulated, and air bubble is used to attach. So this is a post-op picture where the patient has achieved good vision and is doing well. So this is another case, a young patient with 30-year-old lady, and most of these cases are unilateral cases, where it's typically a progressive iris atrophy case, where the particular challenge in these cases are, these are phakic cases. Phakic cases as such, it's helpful in DMEK because the chamber is shallow and it is easy to manipulate, and at the same time we have to be careful that we don't end up damaging the anterior lens capsule. And with these many defects, it's difficult to manipulate the graft also to open up and attach. And so we have to use intraoperative pilocarpine to make the pupil small, and then this is the post-operative result. And this is another case where post-phacoemulsification patient ended up with decompensation, where we have extensive PAS here. The problem with these cases are the graft sizing. The graft has to be smaller, where you have to avoid the PAS, and also you have to make sure the section is not involved. This case we had problem is post-op, the bubble has went behind the pupil and it caused raised diopes, and we have to remove the air bubble on table again. We have to redo the surgery. So this is a post-operative picture where the patient is doing well. And this is another interesting case where the patient was referred post phacoemulsification, where if you look at it, it looks like more of a peaked pupil because of section entrapment and decompensated cornea. But when we look at the other eye, we can see the pupil is correctopia is there. So other eye also gives a clue in diagnosing the eye syndrome. So learning from the previous case, what we are doing is whenever there is iris defects, what we do next day we check and see whether the air bubble has passed above the pupil or not. If that is not the case, we release the air bubble and send the patient. So coming to the study, the outcomes were the BCVA improved significantly from 1.54 logMAR to 0.1, and we also studied the endothelial cell loss, because we never know in eye syndrome what happens compared to the normal PBK cases. And the donor average is 2,895, and at the end of 3 months, the average was 1,305 plus or minus 246 cells. And
time is up, Venkata. So
and none of these cases
we'll stop
needed
your
rebubble.
presentation now because the time is up. Just wanted to ask you some questions on your paper. So very nice cases that you presented. However, this is free paper session, so you should rework your presentation for a free paper in which you have how many cases you had, right? And then rather than showing us each individual case, you to focus more on the results, as in what you were showing in the second last slide. So that should come in much earlier. So because this is not for seeing the surgical technique, like I appreciate you showed the video, but it is more on a free paper. So you just need to work the same content, and I encourage you to publish this also. You write this up in a proper way, and you should publish it.
Sure.
Otherwise, it was really interesting paper, but not presented as a paper.
Okay. Right.
Yeah, great collection, Dr. Prabhakar. All the best.
Thank you.